I would like to take this opportunity to thank all the speakers, the chairpersons, and the moderator of our very engrossing introductory session for GICS. So let's quickly move on to the next topic. As intensivists, we all know the very first step in reversing the pathological process is resuscitation. So very aptly, our second session is about mastering the art of resuscitation. So let me call upon the Chief Moderator, Dr. Ajit Kumar AK, Lead Consultant Critical Care, Astor Whitefield, Bangalore. Welcome, sir. Next, let me welcome the chairpersons for this session, Dr. Satyanarayana Mysore, HOD and Consultant, Pulmonology, Lung Transplant Physician, Manipal Hospital. I welcome you, sir. Dr. Nandita Divekar, Consultant in Anesthesia and Critical Care at Medway NHS Trust. Welcome, ma'am. Dr. Neeraj Kumar, Associate Professor, Anesthesiologist, AIMS, Patna. Welcome, sir. And Dr. Dinesh Reddy, St. Philomena's Hospital, Bengaluru. Now, over to you, Ajit, sir.
So I invite Dr. Sharmili Sinha for the lecture on shock resuscitation, perfecting the balance of fluids and vasopressors.
Thank you very much, Dr. Pradeep, Dr. Ajit and Team GICS for this kind invitee, and it's my pleasure to be here. And shock is, especially septic shock, is one of the topics that we often discuss. And after decades of discussion and research, still we are debating on discussing how to balance or perfect the art of resuscitation, especially in the context of fluid and vasopressors. So these are the learning objective of today's sessions. And what is shock? Just recapitulating the definitions, it is inadequate delivery of oxygen and metabolites at the end organ, that is end cellular levels. And broadly we know it is classified into 4 types of shock. The most commonest in the world, if you globally take a look at the stats, is hypovolemic shock, then comes cardiogenic, septic, which comes under the classification of distributive shock, and the obstructive shock. In context to this discussion today, we'll largely be talking about septic shock. This is the commonest shock that we encounter in our ICUs. There could be a mixed metabolic component sometimes, where there could be a component of either cardiogenic or hypovolemic shock in such cases. Of this septic shock, you know it is defined as a subset of sepsis, where the patient has got profound cellular and metabolic abnormalities, and that is hypotension, persisting hypotension, which is requiring vasopressors to maintain a MAP of around 65 millimeters mercury, and serum lactate levels are high, around more than 2. So I'll just start with a case scenario. He's a 62-year-old man who is a diabetic hypertensive. He has history of fever for 3 days and burning micturations, has history of UTI in the past repeatedly. Now he presents to the emergency department. His blood pressure is low, he is tachycardic, he is hypoxic, and but he is in conscious, he is in distress and agonized. So what is the diagnosis? The quick diagnosis that comes to our mind from the history itself is septic shock, isn't it? And most likely it is a urosepsis. Now what are the concerns in these patients? Firstly, when you see such a patient with hypotension, organ dysfunction, multi-organ dysfunction, to start with you, even before you have any reports in your hand, you start resuscitation with fluids, isn't it? We are very well versed with this concept thanks to Rivers et al. With this EGDT trial. But concerns in this case, and he has also a history of coronary artery disease with 2 stents in situ. So most likely is going to have some element of cardiac dysfunction and also renal dysfunctions, given the long-standing comorbidities of hypertension, diabetes, and now history of repeated UTI. So are you going to apply those blanket rules of fluid resuscitation in this case? Probably not, and we should hear these cases, we should be customizing, right? So what are the physiologies in septic shock when we talk about? Grossly it is divided into this inadequate perfusion pressures due to hypotensions. That is delivery of less blood to the end organ levels at the cellulus. There is microcirculatory failure in addition to that, and that is actually fluid deficit. And this fluid deficit could be actually actual or relative fluid deficit. And there is vasodilatations leading to reduced vascular tone. So the mainstays therapy for this septic shock resuscitation remains fluid and vasopressors. Now how to balance or perfect this act of balancing, giving both fluids and vasopressors, and how to combine, how much and when. We are all well versed with this bundle concept of 1 hour, 3 hour in patients with septic shock. Surviving sepsis campaign guidelines very well rehearsed, and it emphasizes on four factors like measuring the lactate levels and sending blood cultures, administering broad spectrum antibiotics within 1 hour, and start giving fluid up to 30 mils per kg per hour within first 3 hours. Again, the broad question arises that should we be giving this blanket rule of giving 30 mils per kg to all patients who present with hypotension? The case scenario that I had presented is a very classic one. We probably should not be giving. Even within first 3 hours, if I stretch it, we should not be giving. So concerns, we have already discussed this. So why we are talking about fluids? Because largely if you see cardiac output is stroke volume into heart rate. And stroke volume depends on the preload, that is the volume present in our blood vessels, either actual or relatively, and the cardiac contractility. Hence, it is a must to assess their fluid status and assess their fluid responsiveness. Whenever you are talking about fluid resuscitations, you must know how much fluid the patient has already received. In a country like ours, which is heterogeneity across the subcontinent, many patients from the primary or the secondary healthcare centers are referred to the tertiary centers after being resuscitated. And there is no record of whatsoever you to know that how much fluid the patient has already received. Suppose this patient comes to my ICU or emergency, which is a tertiary hospital, I need not be giving just fluid of around 30 mils per kg, that will be around 2 liters for a 70 kg patient, and then start assessing. You must assess these patients before you start even administering fluid and start thinking about vasopressors. And there is no doubt that crystalloids are the preferred fluids in these cases. Look at this surviving sepsis guideline recommendations. If you see, the recommendations for the administration of fluid is been downgraded from strong recommendation to weak evidences. It actually makes me wonder how in the last 10 to 15 years we have been talking about fluids with strong recommendations. Actually, if you look at the literature, there is no strong either research or RCT or any meta-analysis which tells us that this 30 ml per kg should be given. There is very, very low level of evidence regarding this magic number of 30 if you look at literature search. So assessing fluid responsive is very important. Most importantly, basic ones I would say, to start with the clinical assessment of blood pressure and heart rate, and then look at the end organ perfusions. Common man's cardiac output monitor is urine output, 0.5 mils per kg per hour. If a patient is pouring that much of urine after fluid administration with whatever number is on the monitor, his end organ perfusion status is adequate. There could be, permutation combinations of different organ dysfunctions, but end organ perfusion is adequate, right? And now we have heard the previous speakers talking about the CRT, capillary refill time. This has made a big comeback, and even again, Andromeda shock trial, that's the one trial that we know of in the recent times about CRT. It is also adequate. In our clinical practice, we are very much well versed with feeling the patient's peripheries in doing our clinical rounds to assess their end organ perfusion. Now, what about POCUS? POCUS, it has become, in my last 10 years, I have seen it has become such a popular modality in ICU, and most of the workshops always go filled. But you just wonder that why this POCUS or ultrasound has not been able to find a place in the surviving sepsis guideline campaign guidelines. Because I think still, though we are individually doing it in our ICUs, evidence is not available. You do literature search, nowhere you find how POCUS has improved patient outcomes. That is why it has not even found a place in the SSG campaign guidelines yet. We'll see, we'll wait for the 2025-26, I think the next guidelines are due. We'll see if it is coming up there or not. Then if you are lucky and privileged enough, you have this advanced cardiac output monitors where you will get this stroke volume variations, cardiac index, SVRA, etc. And the moment if you have these monitors, it's very big things becomes very easy, and of course you have these invasive lines in place. The moment you give a fluid, you can see how the SVV is varying, SVRI is varying, cardiac output is changing, and accordingly you can customize for your further steps. So remember that there are two category of patients, fluid responders and fluid non-responders. Not everybody, wherever you give fluid, will respond, and that remains still elusive. Having said and done, whatever modalities we try to apply to these patients to assess fluid responsiveness, there is no perfect way where you can say this patient is not responding or not responding. Hence, it is prudent to be cautious after you have given an initial small fluid boluses of around say 10 to 15 ml per kg. Stop there, assess the patient, assess the perfusion status, try to address the root cause and start getting other therapies. And here comes the concept of starting vasopressors early. And I think in the last at least 3-4 years, we have already come to understand, and we are accepting more than before, that vasopressors should be commenced earlier in these patients rather than waiting for that prescription of 30 ml per kg to be over and then hooking on the vasopressors. How vasopressors are helpful? Because these are the ones. Once you start, along with fluid resuscitation, if you are adding the vasopressors, it builds up the MAP, that is the mean arterial pressure, and once your pressure head is maintained, it helps to deliver the oxygen or the cardiac output to the peripheries or to the cellular level, which helps perfusion status. And NORAD is the agent of choice, there is no controversies on that. And the beauty of NORAD is that low dose of it can be administered through the peripheral lines, right? Unlike vasopressin. And many papers in the past have all pointed that noradrenaline is the agent of choice. And next comes the vasopressins. Why and how noradrenaline works? It is alpha-1, alpha-2 and beta-1 receptor agonist. So along with vasoconstriction, it has also got positive inotropic effect. So it also increases the cardiac output to some extent. It also diverts blood from the unstraight circulation to the straight circulations. Thereby it effectively actually uses the endogenous blood volume by diverting and recruits the de-recruited vessels by causing venous capacitance vessels. So this is an article which nicely summarizes the mode of action of all these inotropes and vasopressors. You see at the top, noradrenaline followed by epinephrine and others. So benefit of using noradrenaline, as I mentioned, that it increases cardiac output and also it recruits the microvessels and thus actually prevents the fluid overload, because if you are just incessantly giving fluid up to the waiting for that number of 30 ml per kg, you have probably overloaded the patient, and later if you are starting noradrenaline, all the consequences of fluid overload will manifest after 3 to 4 days. So 4 or 5 studies I will share with you regarding usage, which favors the early use of vasopressors in such patients. This is a study published in 2019, where they started noradrenaline along with the fluid resuscitation as soon as the patients came to the emergency unit. And in these patients, in the late group, they started NORAD once if the patient failed to achieve a MAP of 65 after fluid resuscitations. And these are the outcomes you can see. The time to achieve MAP was much early in the early epinephrine group. The volume administered during resuscitations for both the group was also significantly different. The AKI, which is also a predictor of survival, was also significantly less in the survivors who received early early vasopressors. Similarly, this time to start norepinephrine, of course, was early in the earlier group. The next is the sensor trial. Here in the early group, NORAD was started within 2 hours, along with the almost parallel to fluid resuscitations, while in the late group, NORAD was started if BP was not being able to maintain after 30 ml per kg of fluid boluses. So what did they found in this case? That there was shock resolver time was much less in the patients who were in the early group. So better shock control by 6 hours, less incidence of cardiac arrhythmias and less pulmonary edema, however, no 28-day mortality difference. And now we know that in critical care after decades that mortality difference is not the only outcome that you are looking for. If a patient shock resolution time is faster, it is leading to lesser ICU stay, hospital stay, it is all significant because this has got significant economical or financial implications for a patient in a resource-limited country like ours. Vasopressors, now we know that we have already discussed that noradrenaline is the first agent of choice, and second is the vasopressin. And when do we start vasopressin? This is a very common question which comes in the minds of our young doctors, that when the NORAD doses reaches about around 0.5 mg per kg per minute, that is a standard preparation of around where you are mixing 2 ampules in 50 ml solution. If it is exceeding 10 ml per kg per hour, that is the time when you hook on to vasopressors. This is a paper actually which was, this was the Clovers trial which was published in 2023 and has recruited many patients, and it was carried over at almost 5 to 6 hours. The study publication got halted due to the COVID pandemic, it was said. However, if you see that they compared actually conservative versus liberal fluid resuscitation in patient with septic shock. This is a kind of study which actually has got many flaws if you go through the article in details. Nevertheless, it is published from a developed world, and I would still say that the authors did found that there was no difference in the outcomes among patients who had liberal versus conservative fluid resuscitations. Most of these patients had actually already received 1 to 3 liters of fluid before randomizations. So this was a big fallacy in this paper, and 24-hour fluid approach was assessed in these patients. In our day-to-day patients in ICU, if a patient comes with septic shock, usually after 6 to 12 hours, you are not struggling with the concept of either you have to give more fluids or not versus vasopressors. The matter of fluid resuscitations, boluses, more or less have been settled in these cases, and you are actually focusing on other parameters. So this is another paper by Obstina et al. Also that favor early start of vasopressors in these cases. And hemodynamic monitors, I have already discussed about the ones that we can use. Passive leg rising test is something which we have started hearing about 3 decades ago. I do not use it in my practice in an ICU, and it has got a lot of fallacies. The advanced monitors are available, ultrasound is available, but ultrasound is yet to find a place in SSG campaign guidelines. This is actually a review paper we published last year, and that the unanswered questions, fluid and early vasopressors in the management of septic shock, do we have the right answers yet? So it is summary of what I have already discussed, that once you have given a small fluid bolus of 10 to 15 mils per kg, stop there, assess the patient, end organ perfusion, address the cause, and start vasopressors early. You can use peripheral lines for that matter, buy time to get central line because it requires expertise. And issues in our case, in our countries like us, is that it may not be exactly septic shock caused by microorganisms like gram-positive or gram-negative sepsis. It could be a combined shock like tropical fevers. You have scrub typhus, you have dengue. It could be a cardiac component as well due to cardiomyopathy in those cases. So there will be a vasodilated component, there will be a cardiac component. So it definitely makes sense to have a small fluid bolus of around say 10 to 15 mils per kg, start your vasopressors to maintain the perfusion head, and get your advanced tool and other assessments simultaneously to optimize these patients. So there is other types of shock. Of course, it is a cardiogenic shock. You have to target the heart if it is an AMI or something else, and other advanced assist devices. Obstructive shock, it has to be again targeted. So key points, I would say, get the basics right. Whatever said and done, common things are common and uncommon things are uncommon. So try to focus on the clinical aspects of the case and have a conservative therapy and start your vasopressors early. Thank you very much for your patient listening.
A small announcement. There is a breakaway session happening in Hall B on unlocking financial freedom. If anyone interested can please move on to Hall B. Thank you.
Thank you.
Yeah, thank you, Dr. Sharmili. Now I invite Dr. Anusha Cherian. The topic is resuscitation beyond macrodynamics, optimizing cellular function in critical illness.
Good afternoon, everyone. I am thankful to the organizers for giving me this opportunity, and this afternoon I will be discussing resuscitation beyond macrodynamics. Let us look at this patient who normally rocks up to your ICU on any given day, 56-year-old lady with urosepsis. On admission, she has cold and clammy peripheries, capillary refill time is increased, heart rate is 130, blood pressure is 70 systolic, and her lactates are increased. And after a few hours of resuscitation with fluids and noradrenaline, we see that the heart rate is 120 and the MAP has gone up to 78. However, her lactates and CRT are still elevated. So resuscitation strategies generally aim to normalize global hemodynamic parameters with the expectation that they would result in a parallel improvement in microcirculation and the cellular function. However, this might not happen in all cases, and there might be a situation where the microcirculation does not result in a microcirculatory improvement and there continues to be a microcirculatory shock. So various authors have termed this as hemodynamic incoherence, and this term means that even after you resuscitate the macrocirculation, the microcirculation and cellular function is still not recovered. Further, there are other authors who term this as just the progression of the disease severity. So basically, we don't have any consensus right now about this microcirculatory resuscitation. However, we still need further microcirculatory data to guide in our resuscitation. So when we think about resuscitation, the ultimate goal of resuscitation in shock must be to optimize microvascular blood flow and the tissue perfusion and oxygenation in order to maintain cellular oxygen utilization. So systemic hemodynamic parameters such as cardiac output, blood pressure, lactates are used as surrogates, and this runs a risk of either over-resuscitating or under-resuscitating our patients. So in critical illness, we need to safeguard the oxygen delivery to the tissues. So in the past, we were more after microdynamics outcomes and endpoints, but over the past decade or so, we have been seeing that microcirculation has become the primary focus, and there is a lot of research and clinical thinking that is going on in this. The dysregulated cellular function is still very controversial, so I'm not going to touch into that. So if we think that hemodynamic resuscitation is to be guided by microcirculatory data, then we need 3 conditions that need to be fulfilled. Does the alteration in microcirculation actually play a pivotal role in circulatory state shock? Like, does it involve in the course, in the prognosis? So if so, are there any bedside methods, there are efficient methods that we can assess them with? And do these assessments actually result in therapeutic interventions? So to understand this, let us look at the microcirculation, how it actually happens. So we know the convective flow, it depends on 2 types of flow, the convective and the diffusive. Convective flow depends on the hemoglobin levels and the saturation and the the oxygen content, while diffusive flow actually, the oxygen from the cell going into the mitochondria depends upon the number of capillaries that are available, and it's inversely related to the length that the oxygen has to travel from the blood vessel to the mitochondria. So microvascular perfusion is very closely, tightly regulated by a complex interplay of neuroendocrine, paracrine, and mechanosensory pathways that adapt the local supply to whatever the demand is there from the cell. So these mechanisms, as we all know, is very heavily compromised during states of shock because of the inflammatory mediators, etc. There is endothelial dysfunction, degradation of glycocalyx, leaky capillaries, forming edema, loss of autoregulation, and the coagulation cascade leads on to microthrombus formation. And further, there is microshunting, microcirculation causing shunting, resulting in unperfused vessels. There is dysregulated nitric oxide pathways that are there. There are a lot of decreased perfused capillary density and lot of heterogeneity. So if you look at your this left side, that shows the circulation of a normal patient. If you look at the sublingual microvasculature, you can see that it is densely perfused, while on the other side is a patient who is in shock. The microvasculature at the sublingual area, you can see it is very heterogeneously perfused. So do these alteration in microcirculation actually result in prognostication? So current evidence shows that not a deterioration in systemic variables per se, but rather a failure of the microcirculation to transport oxygen is the primary cause for compromise and leading on to mortality in patients. So this study, there are several studies like this which showed that persistence of microcirculatory alteration is associated with organ failure and mortality in shock patients, even after the microcirculation has been normalized. So how do we assess these patients at the bedside? So microcirculation, we would be very happy if we could have some way to directly measure the tissue perfusion and oxygenation at the bedside. So these are the direct visualization methods. Right now they are in the research stage and not freely available. So we have indirect bedside methods. We all know that the skin is a very important organ that we should look at during any patient coming with circulatory shock. The capillary refill time, the mottling score, the temperature difference between center and toe, peripheral perfusion indices, urine output, lactates, the central venous oxygen levels, the venous to arterial CO2 gap, and further the optical methods like near-infrared spectroscopy, and then visualizing the sublingual microscopy. So this is by far still in the research stage, not freely available, but the microscopes have gone through a lot of advances, and now we have small probes which we can place under the sublingual area to look at the microcirculation. So what do they look at? They look at the flows, which can be graded, the flow indices, the perfused vessel percentage, the functional capillary density, and also the heterogeneity that is there. So all these can be, is how it is recorded. And what does the evidence say? It says that patients in shock showed a higher level of peripheral and tissue perfusion impairment than those who were not in shock. And among survivors in shock, non-survivors tended to show much higher derangement in peripheral perfusion indices as compared to survivors. This is in spite of having achieved a similar kind of macrodynamic goals. Peripheral perfusion indices have a higher sensitivity and specificity to predict mortality in shock patients. Tissue perfusion variables are better than global variables for predicting mortality, and the persistence of the abnormality in spite of reaching your goals of macrocirculation, that has shown to have poor outcomes and organ dysfunctions. So even the studies from microcirculation has shown that there is varying degree of decrease in the total capillary density, RBC flow, and there's heterogeneity that is there. So different degrees and types of microcirculation occur. So is there a chance for individualization like we have been talking from the last session? Do we have an opportunity to individualize therapy? But there are challenges when we use the direct visualization. This is not very easy. There are no clinical implementation is still lacking. No defined endpoints are yet there. And just because there is a microcirculatory circulation failure, which we have visualized, does the improvement of that actually cause an improvement in the patient is still not established. So what are our goals in the microcirculation? So we need to find the tissue oxygenation and blood flow. Then targeting the blood pressure and heart rate was done for the microcirculation. We have seen that the major three large studies did not find any difference in mortality outcomes when they compared the usual care to the goal-directed therapy. However, they took, from the process trial, Massey et al., they took 80 patients out, and they, 40 of them who had died out of shock and 40 who were surviving. And they found that the microcirculatory abnormalities were there in patients who died after 72 hours of the onset of sepsis. And this was even after they have reached a similar kind of macrocirculatory goals. So they further found in all these studies that there is phenotypes that are present depending upon the microcirculatory variables. So what is the target that we look for? For oxygenation, we can look at central venous oxygenation. For perfusion, the gap between the CO2, and a ratio of the difference of carbon dioxide and the oxygen can also tell you about dysoxia. So an increase in the venous CO2 levels due to anaerobic metabolism or a decrease in the blood flow can cause an increase in your venous to arterial carbon dioxide difference. The central venous oxygen saturation comes down when the delivery of oxygen is reduced, and this is a very sensitive to approaches that you do to improve the delivery of oxygen. So that's why you see that the SCVO2 improves rapidly when you fluid resuscitate them. In normal patients, the ratio of the venous to arterial CO2 by the ratio of the oxygen difference is less than 1, and in dysoxia, it is more than 1. So if we have a situation where the venous to arterial CO2 difference is more than 6, there is alteration in perfusion. You can look at the SCVO2, which is less than 70, indicates inadequate cardiac output, while more than 70 would mean impaired microcirculation. We can further look at dysoxia. So how do we target treatment for this? So if we look at the factors, the hemoglobin levels have been tried to increase more than 10 NC, but we have seen that famously it has not shown any benefit. Increasing the oxygen level to supranormal levels have also not shown, in fact, it has shown more harm. Then in order to recruit more capillaries, they have tried giving vasodilators, but this also did not improve. So finally, it boils down to optimizing oxygen delivery, blood flow, and perfusion. And there might be a scope for individualizing this therapy based on your microcirculation. So what happens when you give fluids to the microcirculation? When there is less amount of fluid you give, you have a convective failure. While you give too much of fluids, there is diffusive failure in the fluid resuscitation. So rather than going for pressure targeted hemodynamic monitoring, we go for the flow and functional hemodynamic monitoring, which is basically whatever dynamic methods are using to look for fluid responsiveness. They are all flow based. And this has been reported already that both passive leg racing tests and volume challenges that we give have been shown to improve microcirculation in the sublingual area. And this can further tell you that patient might be fluid responsive. So what happens to the lactate levels, the capillary refill time, and the central venous to oxygen artery or CO2 levels? So we see that there is a biphasic kind of kinetics when we start giving fluids. Initially, there is a rapid fall in the lactate, CRT, and CO2 levels, and this rapidity is faster with CRT. So this is the early flow-dependent phase, which is very responsible to the delivery of oxygen, the improvement in circulation. And this is followed by a late phase, which we would be in danger of overloading if we continue to resuscitate. So the importance is that when your patient comes to the ICU, they might already be in the second phase. They would have already received adequate fluids, and this is important that you keep reassessing these parameters when they are with you. So further, the early fluid therapy has shown better improvement in the perfusion of smaller vessels. And it is not the type, but the time that you give the fluids that has helped. And there is also a microcirculatory index that if it's less than 2.6, if you give fluids, then there is better improvement, and this may lead to personalization. So there are further studies which have shown that perfusion indicators have led to lesser fluid needed for resuscitation. And the Andromeda's shock study, which showed that targeting CRT rather than lactates had led to a decrease in the organ failure. What about vasopressors? So in this study, what they did was they increased the blood pressure map from 65 to 75 to 85 with noradrenaline, but you can see that there is variable different response with some of them improving microcirculation. So again, individualization, and again, giving it early is the key. And there are several other studies showing that. But what about vasodilators? They found that giving the vasodilators did not improve outcomes, probably because they have a macrocirculatory effect as well. So iloprost is a drug that is being worked on now because it has shown an improvement in in the mottling scores after giving this. So probably a role for individualization. So now we have this two types of resuscitation that we need in the early and the late. So probably we need to integrate the macrodynamic interventions in order to look at the microcirculatory response to be integrated and individualized. So these are all the various parameters that you can use and guide your therapy. And there are several methods that you can integrate these two into flowcharts. This is one which uses this map values and then further goes on to SCVO2 levels and further the PaCO2 gap, and then putting them all together to show this. So finally, to summarize, so patients with impairment in microcirculatory perfusion are at risk of development of multi-organ dysfunction in spite of having a macrocirculatory restoration. We need to identify these patients early by repeatedly assessing the microcirculatory perfusion. Direct visualization is still undergoing research. We need to treat and optimize the macrocirculation while monitoring the microcirculation and do an individualized sort of resuscitation for them. And these additional points might still be in the research stage. So I thank you for your patience.
Thank you. So now I'll call the questions will be at the end of the session. Now we have an interesting panel discussion. Resuscitation dilemmas. When do guidelines meet reality? The moderator, I invite the moderator, Dr. Anirban Home Chowdhury. I invite the panelists, Dr. Srinivas Samavedam, Dr. Nirdesh Thakore, Dr. Asina Loba to the dais.
Very good evening. At the very onset, I wish to thank the organizers of the second edition of the GICS into this fabulous place in the garden city of Bangalore once again in the midst of an August gathering to discuss a subject which is known to everyone but also unknown to many. In the morning when we were listening to the lecture, someone was mentioning, one of the speakers, about the cause of perception. So we know many things. There are a lot of known things, there are a lot of unknown things. So between the known and the unknown lies in the perception. And it is all that perception that creates this omics. So when we were listening to the different omics, immunomics, proteomics and metabolomics and all these are old, I was thinking that probably we should also have something called sham omics to delineate or to create a bench level of omics against which we can judge the other omics. So the same thing applies for resuscitation dilemmas, because as we know that there was a gentleman called Samuel Hahnemann who was the father of modern homeopathy, who said that, well, sickness is the effect that the laws of health are not followed. So similarly, death follows because the laws of life are not followed. So whenever there is, so we have to think about resuscitation in the perspective, but that's not always correct. So when we have today a subject like resuscitation dilemmas, there is no better to have an august faculty of Dr. Srinivas Sangvedam, Dr. Mohan Maharaj, Dr. Nirdesh Thakur, and Dr. Ahsina Jahan Lopai. Dr. Subitra is there? Dr. Subit has not come. He is not there? Okay. So the basis of our discussion will be on the three guidelines that are the latest that we follow. That is the 2023 American Heart Association focused update on the advanced cardiovascular life support. We have gone through it, so we have churned out some points from that. We will also follow the ICMR consensus guidelines on do not to attempt resuscitation. That is also a part of our discussion will involve. The ILCOR guidelines and the European Council Association, again, that is the 2023 International Consensus of the Cardiopulmonary Resuscitation and Emergency Cardiovascular Care, so along with the treatment recommendations. Most commonly, if we look into the different scenarios that we come across, that the media pulls up from into its fold with its tentacles, is that elderly passenger suffers a heart attack in a railway station, airport, etc. in a public place, and how someone makes an attempt, a heroic attempt, and he becomes a hero once the patient survives. And even when someone makes a similar heroic attempt, the patient doesn't survive. He remains as unknown as he was. My first question goes to Dr. Samavedam in this regard is that when we look into all these three guidelines, there is a line which comes off and on that this CPR must be started within 4 to 6 minutes from the time of the collapse and must be followed within 10 to 12 minutes of the collapse by advanced life support in order to be effective. My question to you is that how much adherence to this timeline is possible in reality? Is it good enough a timeline that needs to be followed, or can we leave it like that? It should be done as early as possible and not to think about 4, 6, 8, 9, 12. Yes, Dr. Samavedam, please.
Unfortunately, Dr. Anirban, your question is not audible to any of us, actually. But,
I'm not audible.
Anyway.
I think can I have a caller mic, please?
There are a lot of reverberation artifacts which we are getting here. We are not able to hear your question, but I can read it. How much adherence to this timeline is possible in reality? If you want adherence as a dictum, maybe you will find that the 4 to 6 minutes initiation is still not a reality in this country. But an attempt can really be made to do this, because now with calls, compression only life support, which is being accepted by ILCOR as a viable method of resuscitating these patients, and a lot of effort has been made by people like Dr. Chakra Rao sir and all the people in the ILCOR. Taking this message to every nook and corner of the country, if we can do it as professionals and as a society, this adherence to this timeline is definitely a possibility.
Your thoughts, Dr. Mohan Maharaj.
No, as Dr. Samvedam said clearly, as per IRCF and the guidelines, if you see the international national level, even for going for EC pair is going 30 minutes to 39 minutes. And the regular for going for the within 4 to 6 minutes, we are supposed to do the circulation. The only two organs which is going to be in the diastolic time flow is the brain and the kidney. So that should not be stopped for a few seconds also. That's why the first responder should start the CPR, can be done with the society study.
Dr. Nirdesh, I know that they are scientifically speaking, each and every point that they have been, when Dr. Srinivas Sangvedam has mentioned, Dr. Mohan Maharaj has mentioned is correct. In reality, when we want to transform, replicate, practice, how difficult or how easy it is?
Thank you, sir. But it must be started within 4 to 6 minutes and time of collapse. But still, we are lagging behind. As I know, I can't see AEDs even here. So how it is not possible. I basically works in medical college in Udaipur. This sticking to this reality. If you're asking me reality, it usually take around 10 minutes and it finishes that off. So only 10 minutes.
Well, thank you. I'm coming to the next question. We know that regarding the first responder training also, there has been a mention that the goal of an AED program is to have multiple responders and multiple AEDs arrive at the scene of a sudden cardiac arrest in the least amount of time. Well, that is well taken. The AHA recommends defibrillation in 3 to 5 minutes, ideally in less than 3 minutes, and each additional minute without defibrillation lowers the successful resuscitation from a sudden cardiac arrest by 7 to 10%. Please note that these numbers have been quoted from all the guidelines that I have taken for. In order to achieve a good response time and improve the chances of a successful sudden cardiac arrest resuscitation, there must be enough AEDs in the right places, a clear communication pipeline, and enough people trained to respond quickly. My question, once again, I will go to Dr. Mohan Maharaj first. How far is the idea of this public use of AED from reality? Are we too far, too near, or somewhere in between? Am I audible now with this mic? Yeah, thank you. Not to Samvedam. It's not audible.
Echo.
It's like a listening is there, it's okay. We can able to read that. The idea of public use of AED from reality, it's really difficult in India because of the only one thing is a cost. Because AED is a must for every more than 500 people staying or more than 200 people staying more than 50 years of age group, including the hotels and the public areas. That's another important. If you come to the India, it is coming somewhere around 75,000 now to 1 lakh for AED. So that going to the places of the small nursing homes also not available. Where do we get to the public? That's not really reality. Previously we used to have a thumb technique. Now we are going with the AED. Definitely it's useful and that cost should be reduced. And our India is having a multilinguistic way. Only English is coming. Now it's coming with a different linguistic methodology. So that will be definitely improve the use of the reality to the what practice is happening.
Dr. Hasina Jahan, what is the situation in Bangladesh?
No, I must say the availability is a very important thing because first of all, the public awareness and definitely the infrastructure, everything. And the low-income region, I must say that it's not that available in my country. So the public use of AED from reality is a challenging thing. Yeah.
Okay, thank you. Next, I come to another important aspect which we need to discuss is that, which is again we need to know about how close to or far we are from the reality. Comparison between a 30:1 or 30:2 compression to ventilation ratios. Now, for cardiopulmonary, are 2 ventilations necessary? This is a good question because most of the time this has been compiled and imbibed from studies. Although there are no human data available to date that have identified the optimal compression ventilation ratio for the CPR. So it is based upon mathematical and animal models which have showed that the matching of the pulmonary blood flow and ventilation might be more appropriate when the compression ventilation ratios is higher than 50:2. Now that makes both 30:1 and 30:2 suitable. Dr. Samvedam, how far or how near we are from reality with regard to this CV ratio?
So I think now that we have understood that compression only life support is an effective method, I think, and based on what you're showing up here, 30:1 seems to be a practical solution. But there should not be any confusion whether you follow 30:1 or 30:2, because in that confusion, it may become 30:0. So if that happens, then the whole purpose of popularizing this concept is defeated. But technically looking at it, going by the evidence and going by the historical retrospective data of calls, I think 30:1 is a workable ratio.
Your thoughts, Nirdesh?
Sir, I think we are very close to this figure, 30:1. In our hospital and in Udaipur, is a two-tier city, second tier. We are able to do, when we receive patient, we can, even staff know how to ventilate and how to do CPR. So we are doing it and we are doing good, I think. If
Dr. Mohan Maharaj, it is really very important, or is it something that, okay, kind of important?
No, it is important, because if you see the guidelines previously for 5 years back, it was ABC, now it is CAD has come, because circulation is priority. And now the compression only, life support also come. That means the pulmonary circulation is not compulsory. So in that sense, you can go for 30:1 ratio. The second point is that when you are stopping the circulation in between, the sudden fall of what you have shown the previous slide, that is going to take care. So that's the reason that even without that, a 30:1 is sufficient, because the duration should not go more than 5 to 10 seconds in between there should not be stoppage of circulation.
Dr. Hasina, what do you follow in Bangladesh?
No, that is also the same. I agree with the panelists. That is the compression 30:1 is okay.
Okay.
Yeah.
So you can see that there has been a large number of studies, all good ones, which you can see on your screen. But some of them are, of course, observational. Largely, almost all of them are observational. Some of them are prospective, but majority of them are retrospective. And they have seen bystander co-CPR similar to conventional CPR. Almost always they have found that no difference in calls versus conventional CPR. But still then, when we come to real life practice, why is nothing equivocal about calls? What is the reality? I go to Dr. Mohan Maharaj because he was mentioning about calls with this question.
No, because even though if you see the comments of everything, what you have been focused there with the outcome based, you have been saying that conventional CPR is better than compression only life support. It's clear in that. But maybe the person is really trained properly or not is important. If the really trained personnel is there, it may become, maybe over a period of time, it may become equal. That's what is my perception and my opinion.
Dr. Samvidam.
I think it's the mindset. I mean, when you talk about calls, people have a belief that if hypoxia is the main culprit for all the adverse outcomes associated with a cardiac arrest, and if you're not giving that respiratory effort, how can calls be successful? So this is a basic flaw in our understanding about the pathophysiology of the arrest state and how much actually PaO2 do you need to actually have to be circulating to sustain an arrest situation. Once we understand that and understand that the philosophy is to have the blood circulation going rather than pump in oxygen, I think the acceptance and the reality of calls.
So that is a very important point which Samvedam has made, that it is all in the mindset. So that we are not able to overcome. Now that kind of a mindset, it certainly can't be overcome with studies, because it will again will be round the circle and work done is zero. Nirdesh, how to overcome this mindset?
So my point is, we not only doctors, everyone means everyone. A hotel and see any place, they should know see how to do compressions. At least there will be training, multiple training, daily training.
That is a very valid point made by Nirdesh. I get your point. I want to interrupt you there because we have a few more questions to go. But anyway, I think the message is clear that we need to advocate strongly and advocate it among your juniors, among your staff, that we need to advocate this calls practice. Yeah. Now, another important question that also arises when we comes to the closer or distant from reality is one shock versus three shock scenario. If the first shock fails to eliminate the VF, the incremental benefit of another shock is low, and the immediate resumption of CPR is likely to confer a greater value than another shock. We know that. And that's what the guidelines also say, all three of them. The rhythm analysis for a 3-shock sequence performed by commercially available AEDs results in a delays of up to 37 seconds between delivery of the first shock and the delivery of the first post-shock compressions. Now, in the basis of that, what is the basis of decision making in reality and how it is different from the suggested guidelines? Because we are not following this. Although all guidelines are saying the same thing about 1 versus 3 shocks, but we are not following this. Dr. Mohan Maharaj.
The concept of shock, if you see, it's you're going to stop the rhythm. And the only, because of thoracic impedance, the only 4% of the electricity is reaching the heart. So the previous concept of going to the same way, same direction and increasing the next step, and now you have a sequential, double sequential AEDs coming and giving 2 times with the difference of one second. So these things, if you say that, yes, it is going to make some difference, but only sudden cardiac arrest if the cardiac arrhythmia, a reversible cause of the rhythm is there. Otherwise, it's not benefited.
Dr. Nirdesh?
Sir, I think this 1:3 shock scenario, I think 1 shock is better because when anyone is going to give a shock, it's in reality, it takes so much time. So compressions, 1 shock is okay, but
1 shock is okay. Dr. Lopa?
Setup also 1 shock is
Not
okay.
in every setup 1 shock is okay. Dr. Samvedam, if everyone says 1 shock is okay, but why in practice the reality becomes different than 1 shock?
Because we are carried away by correcting the rhythm rather than sustaining the perfusion pressure. So we are caught up with that, again I would say mindset of this rhythm is the cause of the arrest, so I need to correct the rhythm. But if you're not able to achieve in first shock, I think the focus should be back on restoring the coronary perfusion pressure rather than restoring the rhythm.
And that has been clearly elucidated nicely in the ILCOR 2023 guidelines, if you go and find it in the pages between 44 to 48, and this has been what some of them has just now said, has been elucidated with a lot of other principles and diagrams, and it is really important to understand that second and third shock becomes meaningless, fruitless more often than not, what we can think of. Next important question, again it comes into the guidelines when we compile all the 3, is amiodarone. There are a lot of yes and there are a lot of nays as well. In CPR, amiodarone influences the response to defibrillation when administered for VF or hemodynamically unstable VT, and amiodarone improves survival chances to hospital admission, providing superior to lignocaine. That is the word which one the guidelines uses in terms of survival to hospital admission. IV amiodarone was shown to provide clear short-term benefit in the ARREST trial and in the ALIVE trial. Now, despite all this, what are the real risks of administering amiodarone following acute heart failure, say due to MI, which is a very common cause of sudden cardiac arrest, and we don't use, and rightly we don't use amiodarone, although the guidelines say with the proofs that it needs to be used. Some with them.
I think one of the biggest effects or the most significant hemodynamic or cardiovascular effects of amiodarone is on the QT interval. Whatever you do, it prolongs the QT interval. So there is a school of thought which believes that some of the refractory VTs, VF that happen after administration of amiodarone is because of its effect on the QT interval. So that may be one of the issues. And the reason why it fails or we don't get the deserved benefit is the heterogeneity in the way it is administered across. While you say that this is the dose of amiodarone and this is the timing, how do you administer it and what do you do after administration? That aspect is not given as much focus when ACLS is taught to the students.
That is an important. Anything you would like to add, any one of you? No?
Actually, we are using amiodarone and we know that it is not out of risk and hypotension, bradycardia, anything can happen. But still we use, and I think the hemodynamic status is very important. It can be individualized patient to patient. I mean, yeah.
Okay, that's fine. In good old days, the teaching used to be that whenever you are not sure whether it is ventricular or supraventricular, give amiodarone. But that is not the case today. Now we clearly distinguish and delineate the two things separately, and we know the reasons as well. Well, again, another important where we need to draw our lines and get ourselves close to reality is about vasopressin and glucocorticoids, because in hospital cardiac arrest, these two drugs have have been a kind of Rohit Sharma versus this Ashwin kind of a situation. Vasopressin may cause less pulmonary and cerebral vasoconstriction than epinephrine and improve the regional cerebral blood flow. The chances of further damage to the brain, etc., becomes less. Equivalent results were observed for vasopressin compared with epinephrine when used as an initial vasopressor during resuscitation from cardiac arrest. And vasopressin have vasoconstricting efficacy even in severe acidosis when catecholamines are less potent and maybe more effective than vasopressor than epinephrine in patients with asystole. Now, this is all the guidelines say. In reality, it's something different. Now, are all these observations real for practical purpose, or there is many a slip between the cup and lip? Dr. Mohan Maharaj, please.
With the evidence of the studies, it's real only. Because only practical purpose means where these kind of things cannot make a randomized control studies cannot be made, all these things. So that's the reason that it's, yes, as per the number of patients it's included, definitely that's what you have been said, the bench is right, acceptable and good.
Dr. Nirdesh Thakur, you use vasopressin first or you use epinephrine?
Yes, sir. Truly speaking, we use epinephrine, but if it's available, then I can give vasopressin. That is
you
my
can, but you don't. Dr. Lopa.
No, we widely available, definitely epinephrine, and we are using it. So availability is important, but we are using most frequently, that is epinephrine.
I get your point. Dr. Samavedam, what is the root cause behind this?
The root cause is non-intensivists believe that vasopressin is a toxin. And it causes gut ischemia, it causes myocardial ischemia, it causes so many problems. This is the thought process of non-intensivists, whereas intensivists believe that epinephrine causes lactic acidosis. So it is our belief. So in this clash of beliefs,
it is a clash of titans.
Not titans, superstars versus a lesser star. I think vasopressin loses out. That's the problem.
Anyway, so that is a very something we need to understand, review, and then come. Then lastly, I go to this case, a 30-year-old male, a traumatic brain injury with loss of consciousness, vomiting with a poor GCS. You can see E1, V1, M2. The fundus reveals papilledema, ONSD is 3 mm, NCCT head shows cerebral edema, midline shift, cerebral contusions, and ICH. Treated conservatively with mannitol, nimodipine, prophylactic levetiracetam. On day 7, the GCS is E2, VT, M3, ICP still raised, EVD has been placed. On day 9, the patient remains hemodynamically stable. The GCS, there is no improvement, but patient develops sudden VT, followed by VF, successfully resuscitated. Please note each and every point. Next day, similar episode, patient survives resuscitation. Same day, the patient again develops hypotension, bradycardia, asystole, and again CPR has been started. I go to Dr. Mohan Maharaj. When should we consider not to resuscitate in such a scenario? It is not a pure open and shut case where we can say that patient is gone.
No, it's not like that, sir. As you said rightly, is GCS is E1 to VT and M2, and here also E2, it's actually improved if you see that again. So that you take the family consent, then think about it.
Patient has not deteriorated also.
Yeah. So when we should consider not to resuscitate, because again you need to go back to the same. You have to start
resuscitation guidelines don't mention specifically in such cases of it. Probably it's a gray area, but would you go for resuscitation or you won't?
No.
You will go for it. Yes. Nirdesh Thakur.
So first, honestly speaking, on the day 9th, GCS is E2, VD, M3. But when if
no, E2, VT, M3 and all, you can imagine a situation. Don't judge anything by E2, VT, M3 or anything of something
so
like that. But you can imagine that this is a situation in which the patient is experiencing.
Trust me, day before yesterday, I faced this dilemma. Honestly speaking, I will not resuscitate.
So this is a dilemma for you for which there is no answer.
Yes, there is no answer.
Dr. Lopa.
I will try to resuscitate.
What you want to do?
I will not, I will try to resuscitate again.
You will go for resuscitation actively.
Yeah.
Okay. Some of them, in such scenario, what is the answer? Because the guidelines have not been able to reach anywhere or take us anywhere, lead us anywhere.
So it looks like this patient had no risk factors for any coronary event or whatever.
Yeah.
So there must be a treatable cause for the VT and VF. There must have been an electrolyte disturbance, some of those things. If those are triggering the VT, VF, we should correct it and give him one attempt at restoration of spontaneous circulation. If you can't do it, we give up.
So there are a lot of unseen and unforeseen situations where the guidelines probably are not able to take us or guide us in the best possible way, but definitely they will be able to give us some amount of the add to our wisdom, which we acquire from both looking into the guidelines plus practicing the science and the medicine of it. And we can certainly understand that sometimes it is necessary to take a step backward to take 2 steps forward, because everything cannot be translated as much as can be expected. So I thank once again all the panelists for being with us, and I thank all of you for being a part of this panel discussion. Thank you from everyone from the GICS organizing committee. Thank you.
I invite the next speaker, Dr. Ayyappan. The topic is trauma resuscitation, the ticking clock, strategies for rapid assessment and intervention. I request the chairpersons to be back to the stage, Dr. Dinesh Reddy, Dr. Satyanarayana Mysore, Dr. Nandida, Dr. Neeraj Kumar.
Good afternoon. Shall I start, sir? Yes. So good afternoon. I would like to thank the GICS organizing committee for giving me this opportunity, especially Dr. Ajit sir and Dr. Pradeep Rangappa for giving me this opportunity. And without much ado, I will go into the topic discussion per se, which is trauma resuscitation. So when I was looking at this, I saw this WHO 2021 chart or map, which showed that the trauma outcome secondary to RTA in India is on par with Western standards or world standards, or even superior to it, and probably we are the best, we have the best outcomes in the Southeast Asian countries. So I was alarmed by this because what I thought was probably the trauma care requires better coordination in our part of the country. So when I was looking for evidence to suggest that, I found a paper where, even though it was not a well-matched study, I found that when a comparison was made between the trauma patients in US as well as India, there was increased mortality in India compared with the propensity matched population in the US. The more alarming thing was the mortality was more in the younger population as well as in the less severely injured patients. So this was more in line with what probably was a real fact. And with this, we'll go into the mortality in trauma, which classically follows the trimodal distribution. If you look at the mortality in trauma, it has 3 peaks: the early peak, the late peak. The early peak happens because of the immediate trauma-related injuries, and majority of the patients don't reach the hospital. They will be either dead in the field, or while they reach the hospital itself, they will be moribund. And the late complications or the late death, which contributes to nearly 20%, happens because of the so-called complications of the second week of ICU stay. And it is this 30% of the population who reach the emergency in time, who requires the proper resuscitation so that they can have a possibility of surviving out of this trauma. So when we look at the resuscitation in these patients, so the ATLS has come up with the primary survey and secondary survey for a protocolized management of these trauma patients, and what we follow is the ABCDE approach. I won't be going into the individual details of it. The topic of discussion will be in circulation. So what causes hypotension in trauma? If you look at trauma, the trauma can cause shock in all formats. In other words, it can cause obstructive shock by cardiac tamponade and tension pneumothorax. It can cause distributive shock by neurogenic mechanism. It can cause septic shock by a delayed presentation from a peripheral center, and it can also cause cardiogenic shock because of chest wall trauma as well as a hypovolemic shock. But shock in trauma is hypovolemic or hemorrhagic unless proved otherwise. So how do you recognize shock in these patients? This is a strange question because majority of the shock, we will be confused how to treat the shock, whereas in hemorrhage alone, we will be confused how to recognize the shock. Because once you have a hemorrhage, what happens is, because of your aortic and the carotid baroreceptors, what happens is you have increased sympathomimetic activity with the decreased vagal tone, which results in significant vasoconstriction and tachycardia, directing majority of the blood volume into the central circulation to maintain the perfusion of your brain and the heart. So you don't have a shock as defined by decrease in blood pressure. In other words, you will have tachycardia with increased diastolic pressure and narrowing of the pulse pressure rather than a drop in systolic blood pressure. So this is what you will come across in shock, and this is again shown in this American College of Surgery classification of shock, where you see a drop in systolic blood pressure happens only when there is 30 to 40% of blood loss, and by the time you recognize shock in these patients, almost 40% of the blood has been lost by these patients, and if you are going to resuscitate only at this phase, you have already lost the boat. So recognizing the shock at the earliest is going to make the change in these patients. So how do you recognize shock? So the most early signs will be a cold, clammy peripheries with a narrowed pulse pressure with sinus tachycardia, followed by a lab value of a base deficit more than -6 and an increasing lactate. Your hemoglobin and hematocrit may be falsely high because you lose blood products. When you lose blood, you lose components as well as cellular elements. So how do you resuscitate these patients? As usual, you give crystalloids. If you have less blood loss, you will respond. Those are the rapid responders, and those are people who have lost significant blood. Even if you give crystalloids, there won't be any response. They are the people in the extremes. They won't respond to your crystalloids. It's the people who are in the middle, the transient responders, whom you have to be very active, where you have to be very vigilant and identify the source of bleed and control the bleed so that you can salvage them. So coming to this, there is an interesting history to resuscitation. It was in the 1960s. Majority of our resuscitation comes from the battlefield, where the Shire et al. Told that the resuscitation should be with large volume crystalloid resuscitation. In spite of having high mortality, this was the practice which was followed for nearly 40 years. And it took Rotonda et al. In 1990 to come up with the damage control resuscitation which we practice here, and back then it was not supported by many traditionalists. And it was only after 8 years after this study, American Army Medical Corps published in BMJ consensus that the trauma has to be handled in a different way with damage control resuscitation. So this is the basis in which we are resuscitating trauma patients. And how do we resuscitate them? We resuscitate based on these goals. How do we? We try to restore perfusion, we try to control bleeding, we try to minimize iatrogenic injury, and we try to promote hemostasis. All happen simultaneously, not one after the other. So how do you restore perfusion? The perfusion should be restored by blood and blood products. You lose blood, you replace blood. There is no point of giving crystalloid because you are not going to increase the oxygen delivery to the tissues. You are going to cause more harm. And lower the ratio of blood and blood component transfusion, the better is going to be the outcome. And you have to activate your massive transfusion protocol early so that the massive transfusion protocol itself is a misnomer, because activating massive transfusion protocol early results in less transfusion of blood products rather than activating it late. So how did we come to the conclusion of lowering the ratio of transfusion improves outcomes? It's based on two trials, which is predominantly the PROMPT trial and PROPER trial. Even though it did not show any mortality benefit at 28 days, both of them showed significantly reduced mortality at 24 hours secondary to exsanguination, which is what we look at when we transfuse blood products. And how do we activate the massive transfusion protocol? You can use any of these scoring systems. The most commonly used ones are the ABC scores, TASH score, ETS score, and as well as the RAPT score. The ABC score, the advantage is you don't have to rely on labs. You have to look at only the clinical parameters, and you have 75% sensitivity of massive transfusion if you have a score of more than 2. And RAP score, instead of looking at your heart rate and systolic blood pressure, it uses shock index and the pelvic trauma, so it carries a better sensitivity of predicting massive transfusion. So of late there has been interest in the transfusion of blood products and blood product. Instead of transfusing blood and blood component, why not whole blood? Again, this is also extrapolated from the military studies, because the whole blood contains less preservatives, it contains less chance of infection, it has more functional coagulation factors, it has more functional platelets. And if you can look at this, A 675 ml of blood and blood component therapy can be replaced by 500 ml of whole blood. But it is too early to comment on whether the whole blood should be the standard of care because it has not been still used in the civilian setup. It has predominantly used in the military and the naval research purposes. So coming to the next, control bleeding. Control bleeding at all costs. So how do you can use any mnemonic but try to find the source of bleeding. You can use scalper mnemonic or the most commonly used blood on floor or 4 more. So you have a exsanguinating peripheral extremity followed by a torso bleed. It can be in the chest, it can be in the abdomen, it can be in the long bones, or it can be in the pelvis. Try to find out the source of bleeding. You use your armamentarium, especially your ultrasound, do your E-fast, identify where the source of bleeding. Is it without pitfalls? No. Your ultrasound can miss when you have subcutaneous emphysema, when you have obese, morbidly obese patients, and when you have retroperitoneal hematoma, it might be missed in the ultrasound. So the biggest negative point of the ultrasound is its false negative results. If you have a false negative E-fast, you tend to be negligent and it results in worse outcomes. So reassessing a fast increases the sensitivity, and when you can't identify the source of bleed in a probably stable patient, go for other invasive tests, probably a contrast-enhanced CT, and in an unstable patient, go for damage control surgery or take the patient to the cath lab. So next, control the bleeding. You have to either control the bleeding with pressure, tourniquet, surgery, suturing, do whatever it takes, but control the bleeding. Without controlling the bleeding, you cannot maintain the perfusion. So again, there was this Stop Bleed campaign which was used for the layman in 2013, where they educated the layman about the use of compressing the bleed. So what they advised was, when you have a peripheral extremity penetrating injury, you use your pressure to control the bleeding, and if not, they train them with a tourniquet. You use the 7-step compression technique to stop the bleeding, and if you could achieve stop the bleeding in a peripheral penetrating injury by tourniquet, it was associated with better outcomes. If you see, when tourniquet was used, this was in 2022, which was published in JAMA, when peripheral penetrating injury with exsanguination was there, when tourniquet was used, the more severe patients even reached the emergency without shock, and there was no limb emergencies. And the control of bleeding in a trauma, in a current scenario, cannot go away without a discussion on RIBOVA. What is RIBOVA? Resuscitative endovascular balloon occlusion of the aorta. So it is placed in 3 zones, zone 1, zone 2 and zone 3. What is zone 1? It is between the subclavian artery and the celiac artery. The zone 2 is between the celiac artery and the inferior renal artery or the lower renal artery. And the zone 3 is between the renal artery as well as the bifurcation of the aorta. So when do you use it? When you have a torso bleed which you cannot localize and patient is in agonal state where you cannot do a exploratory laparotomy, or he is even unfit to undergo a damage control surgery, you do RIBOVA. The most common sites where the RIBOVA is employed is either in zone 1 or zone 3, but it has not given successful results. If you, as shown in this retrospective study, it was associated with increased mortality and delay in shifting to the OR or the cath lab. But this study, when it was compared with the resuscitative thoracotomy, it was associated with better results. Even though majority of the patient died, few less died in the RIBOVA group. So control bleeding, again damage control resuscitation and damage control surgery. What do you do in damage control resuscitation? You do permissive hypotension, you do less crystallite transfusion, you do product transfusion, and you control the hemorrhage. So what do you do in damage control surgery? You go in, quickly come out, clean the contamination and control the bleeding, and do not do heroic activities. So minimizing iatrogenic trauma, I will finish fast. So limit your crystallites. Blood cannot be replaced with crystallites. The more the crystallites you give, the more will be the acidosis, the more will be the immune effect, and more will be the disruption of the clot. The most harmful thing will be, by improving the peripheral perfusion, it will prevent the peripheral vasoconstriction, thereby causing more bleeding to happen. So avoid crystal administration to avoid the worsening of lethal triad. So this is again another study which showed that immediate and delayed fluid resuscitation did not show any. The delayed fluid resuscitation was associated with better outcomes. Again, the role of vasopressors, don't jump on giving vasopressors in hemorrhagic shock. The role of inotropes in hemorrhagic shock is limited. There has been a recent study called the avert shock trial which showed that a low dose use of vasopressin was associated with the decreased blood product transfusion. promote homeostasis with tranexamic acid with crash 2, crash 3 trial, and cryoprecipitate, TEG, ROTAM and prothrombin complex has not shown any significant benefit. So take home message, use your blood products for resuscitation, limit crystalloids, beware of the lethal triad of trauma, and strictly adhere to the damage control resuscitation, and try to form a trauma code which suits your institute. I will stop with this. Time spent in ED in resuscitating a patient is time lost in OR, which will have adverse outcomes. Thank you.
So thank you, Dr. Ayyappan. Now we have the discussion. I invite the speakers to be on the stage, Dr. Sharmili Sinha and Dr. Anusha Cherian. So any questions from the audience?
So just about the trauma resuscitation, I think in Indian scenario, most of the patients, obviously this is a critical care forum, isn't it? Like I think when we see trauma, most of the time we acquire severe trauma, not a minor trauma with the hemorrhagic shock, and most of the time they tend to come to us, most of the tertiary care centers, a bit late. And so, as much as most of these guidelines are saying that please don't give more than a liter of crystalloid before you give blood, most of the hospitals don't have in-house blood banks, isn't it? Right? And number two is that amount of blood products that you can acquire, even if you can acquire, is a lot more limited. And so how would you personalize, let's say, in a hospital where a severe trauma with a hypotension comes at least 3 hours after with a 60 systolic with probably blunt trauma injury in an Indian scenario? Clearly that we have done audit, we cannot follow the ideal guidelines anymore, for sure, whether the crystalloid or whether, when to use the vasopressor, when to use it. So how would you do in your practices?
Sorry, the question is a hypotensive patient coming to the emergency.
Yeah. 60 systolic, 3 hours since the injury, blunt trauma, so hypotensive. So, like, and obviously.
So, basically, the initial resuscitation has to be crystalloid. So, the crystalloid, but limited to more than a liter. Restricted to a liter, and you have to start inotropes and target for perfusions rather than for your BP. You look at your base deficit and because your lactates and try to maintain the perfusion to the vital organs rather than normalizing the blood pressure till you get your blood products. Because if you try to normalize without getting blood products, even if you are ultimately going to lose the patient.
Yeah.
So without getting blood products, I don't think it will make any difference in a hemorrhagic shock patient.
Right.
And there is an interesting prelude to this. There was a study which was published in 1994 where they told there was the patient groups, there was a comparison between a SBP of 100 and SBP of 70, and there was comparable mortality in both the groups. So how did they come to this conclusion was that there was a trauma center, and they noticed that the people who came through on their own had lesser risk of death or lesser complication rather than people who came through emergency services. In other words, people who are not resuscitated in a hemorrhagic trauma had better outcomes. That is how they rationalize the lower blood pressure target. So we have to try to maintain the perfusion with probably crystalloids and inotropes, but until and unless you correct the blood loss with the blood, you won't be able to get the end of it.
What is your opinion about use of, obviously nowadays we have